Before we start today, I want to acknowledge with respect the Indigenous peoples and communities whose historical relationships with the land continue to this day and on whose traditional territories our work takes place. While we meet today on a virtual platform, we can take a moment to acknowledge the importance of these lands, which we each call home. So my name is Autumn Sipis. I am a project manager for the Canadian Coalition for Green Healthcare, and on behalf of the Coalition and Cascades, I would like to welcome you to today's webinar, Nix the Nitrous, Updates from the Field. This webinar is being presented as part of the Coalition's Preparing Canada's Healthcare Buildings for Net Zero project, made possible with investment from the Government of Canada's Low Carbon Economy Implementation Readiness Fund. Gotta take a breath after that. So throughout the event today, please use the chat function for any technical issues you may have throughout the event, and use the Q&A function for any questions you have regarding the presentation. The presenters will be answering questions at the very end of the event today. We are also recording this webinar, and the recording will be sent to all registrants as well be available on our YouTube and website at a later time. I'm now going to hand things off to Dr. Anita Rao to introduce our speakers and set the stage. Take it away, Anita.
Okay, thanks very much, Autumn, and thank you to the Canadian Coalition. So we are the Nix the Nitrous team, and we have several presenters from that team today, and their biographies can be found on the slides. Next slide, please, Autumn. And I'll just go over it briefly, but their full biographies are here. So Mike Apostol is the Energy Management Specialist at London Health Sciences Centre. Lisa Hutchison is an anesthesiologist and critical care physician from Southlake Hospital. We have Kathy DeCoven, who's a practicing pediatric anesthesiologist at St. Justine in Montreal. I'm Anita Rao. I'm an anesthesiologist at Trillium Health Partners in Mississauga. And Stefan Williams is a practicing anesthesiologist at CHOM in Montreal. Asim Iqbal is our BC lead, and he's unfortunately unable to be with us today. Next slide, please. So our learning objectives, this is more of an update and a follow-up from our webinar a year ago, but we will go over some background, review the current clinical indications for nitrous, and discuss why it has a very limited role in modern practice, explain the environmental and economic impact of central nitrous distribution systems and outline approaches to decommissioning and answer questions about that as well. We will also discuss why you should avoid any new central nitrous distribution system in a new build. We'll summarize the current state of nitrous decommissioning, and there's been a lot of activity in the country in the last couple of years, and identify key barriers and stakeholder strategies. And with that, I will present Dr. Williams.
Right. Thank you very much, Anita, and thank you to all you who are listening to us tonight. And I'm going to take about 5 minutes of your time and tell you about what hasn't changed, why healthcare needs to become sustainable, and why nitrous is incompatible with sustainable medicine, and tell you a little bit about what's new in Quebec also. So I need to get control for the next slide. So sustainability hasn't changed, obviously, and sustainability is still and will always be a pyramid built on the foundation of a healthy biosphere. And the cornerstone of a healthy biosphere is a relatively stable climate. So for too long, we've been trying to create good health and well-being, which is also a sustainability goal, while ignoring our impact on the biosphere and particularly on the climate. And if we keep doing that, well, nothing that we're doing will end up being sustainable for very obvious reasons. The other thing that hasn't changed is that we are in a climate crisis caused by an increase in atmospheric greenhouse gases that is creating an increase in the Earth's temperature, and this is very bad for our health. The increase in the Earth's temperature is caused by the emissions of about the equivalent of 50 billion tons of CO2 a year, mostly in the form of carbon dioxide, the main greenhouse gas, but also methane and also nitrous oxide, which if just go back one slide, is the third most important greenhouse gas in importance. So we emit relatively little nitrous oxide, but it has a disproportionate climate impact because, as you see in this slide, each 3 kilo e-cylinder of nitrous oxide warms the planet about as much as this huge ton of CO2 on the left side. Nitrous is about 300 times more effective than CO2 at warming the climate. It's because nitrous is such a powerful greenhouse gas and because it's used in medicine that even when we're trying to decarbonize an entire healthcare system, there's usually a section in the plan specifically reserved for nitrous oxide elimination. The other thing that hasn't changed is I work at the CHIM, which is still the biggest and most modern of Quebec hospitals, and also unfortunately has ended up on Canada's map of worst greenhouse gas emitters and is still there now. Now, the CHIM was built with central nitrous, and thankfully, this central system has shut down since 2022, and that leads me to what's new. And the first thing that's new is that we now have 3 years of data in anesthesia at the CHIM, where we've performed about 55,000 hours of anesthesia every year, and that's been pretty constant over the last 3 years. And over the 3 years since central nitrous has been shut down, we've ordered 0 e-cylinders of nitrous oxide. So we produce essentially 0 tons of nitrous oxide climate pollution. So that is good news. And we're happy to have not only shut down our central system, but transitioned in anesthesia to, I think, anesthesia that is better than what we did before and doesn't use nitrous oxide. This is in accordance with the recommendations of our INES, our National Institute for Healthcare Excellence, that recommended shutting down central nitrous systems and not using nitrous as a carrier gas in anesthesia and using nitrous for sedation only in very special cases. The Quebec Healthcare Ministry usually listens to its own INES, but it spent the last year splitting itself into 2 entities. Now we have a ministère that does strategy and something called Santé Québec that's responsible for operations. That means that the ministère can now kind of write to itself, and it did in March 2025, and it wrote to the Santé Québec part to ask them to follow INES recommendations, shut down central nitrous, and not include in new builds. As of early 2026, there is no sign of a provincial shutdown initiative. Central nitrous shutdown is still proceeding, but ad hoc, hospital by hospital, and there's still no provincial data except that collected by the Quebec Association of Anesthesiologists. We know all this because reporters have become interested in the story. It is a good story, and they are producing news about how this is proceeding or not proceeding. The Quebec Association of Anesthesiologists surveyed its members back in 2024, and at that time, about 40% of departments had already shut down or never had central nitrous systems, and about 40% of departments also didn't use nitrous clinically anymore at all. Right now, we're right in the midst of redoing this survey, and we're not finished yet, but we do have more than half of our centers that have answered. And what we're seeing is that things are getting better. We're probably around 60% of centers that no longer have central nitrous systems, and also 60% of departments that are no longer using nitrous clinically. So that's a very positive change in the last 21 months. And what's interesting is that, again, it's not the same centers that have shut down central nitrous and that have stopped using it clinically. The other thing that we have now are position statements from other clinical stakeholders. This is the Quebec Association of Emergency Physicians, and they've come up with their position statement that says shut down central nitrous and don't install in new builds. Don't use nitrous for adult sedation, and in peds only for select cases where other analgesic strategies have been exhausted. We also have this great position statement from the Quebec Order of Midwives now that reminds us that nitrous is a weak analgesic with very limited efficacy, that other analgesic methods offer similar results with much less environmental impact. And they have this great sentence that reminds us that nitrous is a powerful greenhouse gas that, if used during childbirth, will still be impacting the climate and the health of the great-great-grandchildren of the baby being born. It's also potentially toxic to healthcare workers. They tell us patients should be informed of all this well in advance of giving birth, that central nitrous should be avoided, and that clinical use should be minimized or eliminated. So to summarize, we now have agreement across multiple clinical stakeholders in published official position statements. We have no need for central nitrous and little or no clinical indications left for nitrous oxide. The shutdown of central nitrous is progressing, still hospital by hospital, but hopefully 2026 will be the year for systemic action in our province. Thank you very much.
And I just want to review that nitrous oxide is not just bad for the environment, it is actually very costly. And it's costly partly to maintain the central system and to repair the leaks. We do have to have regular occupational testing. And since it has very few clinical indications, it's expensive, and it's not a particularly good drug for patients. It follows the principle of the triple bottom line. At my hospital, we save $90,000 a year by having it shut central nitrous down in all three of our centers, our hospital sites in our health system. Next slide, please. The shutting down of the nitrous system is not only just supported by the Canadian Anesthesiologist Society, which has two statements, actually one position statement on the environment that advocates for the shutting down of nitrous and not to include in any new builds, but it is actually within our guidelines to the practice of anesthesia. So in fact, it is recommended to be practicing within Canadian guidelines to eliminate nitrous to the extent possible, which would also mean shutting down the central system. The World Federation of Societies of Anesthesiologists, the American Society of Anesthesiologists, as well as, the Royal College of Anaesthetists in the UK, have all issued similar statements. And next slide. And we have a few other organizations, such as the Institute for Healthcare Improvement, which is in the Joint Commission in the States, which have also advocated for the decommissioning of nitrous, as well as not including in new builds. Next slide. So obstetrics is one area where nitrous is still used, often for analgesia. It can be used as a stopgap measure if you are waiting for an epidural or in areas where you don't have easy access to on-demand epidural. It's not particularly efficacious, as Dr. Williams pointed out, as in their own statement from the midwives, but some hospitals do feel that they still require portable systems for their labor and delivery. And these are just some examples of how you can use portable nitrous, which is much, much less toxic to the environment because it is not leaking. And I'm going to hand it over to Mike now for the facilities portion.
My view of it, because I work in facilities, but also care about the environment. Why should facilities support Nix the Nitrous? So centralized nitrous oxide systems, as you've kind of heard, have this very high leakage rate. Everywhere it's been checked, it's pretty much over 90%. I can tell you at our own hospitals, one of them was 90%. The other one is like 99.9%. We actually have two systems in that hospital. I've decommissioned one last summer. The other one is going to be this spring or early summer as well. And there's not really a way to get away from that from even an audit perspective, because the nitrous oxide molecule actually diffuses through the flexible hoses that are in the OR boom. So it's constantly diffusing. And then on top of that, you have all the point leakages at the terminal units or any other type of connection in the entire distribution system. And these systems can be very vast and quite large, and they are difficult to actually audit from a maintenance perspective. A lot of the plumbing and connections are behind walls and in ceilings. Terminal units are relatively easy to check, but if a terminal unit starts having a low-level leak right after it had just been checked, it's another year before it gets looked at again, typically, unless someone notices a very loud noise coming out of it. So the leakage is one of the main issues. So it's a very inefficient gas, and it's expensive to maintain. So every time you find a leak from your audits, you're having to pay to replace them or fix them. It's also you're paying for the nitrous oxide gas itself, plus the space that it takes up to store all the large tanks that supply the centralized systems. There's a potential for leaks to also impact indoor air quality. Um, I mean, Anita referenced that where, you do sometimes need to do air quality inspections. Some hospitals do that, some hospitals don't, just it varies hospital to hospital. But yeah, there's lots of reasons to support this initiative. I think I can click right. Maybe that
You just
did
need to
not.
go to the arrows at the bottom, Mike.
Oh, okay.
Yeah.
Weird. Okay, there we go. So this just lists some of the hospitals that here in Ontario and across Canada that we've done audits on, and you can sort of see the impact. We're in the hundreds to thousands of tons of CO2 a year just from these systems, and we know that because you can compare the clinical usage that's captured in it in the anesthesia machines to the actual purchased nitrous oxide by the respirology department or through facilities. So we've created these resources. They're fairly comprehensive. We have the nitrous oxide toolkit that is available. It goes through everything kind of step by step. There's a decommissioning checklist that gives you can use that to track your progress. You can input, values that you're finding as you're doing the decommissioning process and getting your stakeholders together and aligned with what's next. And then there's a cost estimation tool as well that I've created where you can see examples of a large, medium, and small nitrous distribution system, what the costs typically are associated with that, and then you can even modify it to match whatever you have and what you'll need to. I highly recommend checking out the tools. They're very useful for building the business case on these things. Things to keep in mind is that you do not need to remove all the nitrous oxide distribution piping unless you want to. I don't know anyone that wants to generally do that because it is buried in all the walls and the ceilings, and it is a nightmare to do. It would be wonderful to do practically for a decommissioning exercise. You can leave it in place in case you ever decide to re-implement the centralized system in the future. Um, Another thing to keep in mind when you're starting down this process is sometimes medical gas drawings and or the vendor audit list may not be up to date. If you work in facilities, that'll make total sense to you. Outside of facilities, you'd be like, why aren't they up to date? It's just a reality of the situation, but it does help to do kind of your own personal checks, validate the drawings and the med gas audits that you're doing. But you can use those med gas audits, the annual ones, to at least figure out generally how big your system is, and whoever's doing the audits for you should be able to supply that information. Also, the decommissioned alarm panel cards can be utilized elsewhere. So at our hospital, the one we decommissioned last summer, we have an older alarm system that they don't make parts for. So when we run out of cards, we basically have to pay $20,000 to upgrade to the newer style of alarm panels and shut-off valves integrated system. So as we're decommissioning all these systems or the nitrous oxide panels themselves, we're pulling the cards, and those are now spare parts that are allowing us to add more longevity to our existing systems, which my facilities manager was like, that alone paid for the entire thing for that one system we did. And when we do the second system that's there, again, it's going to save so much money because it costs so much to do those upgrades because they don't support these older systems anymore. But you can see here kind of what our system looked like after decommissioning. There's a terminal unit on the left there. It has a plug that you can't just unscrew. So it prevents anyone from using it. There's stickers that go on the nitrous oxide alarm system. And then again, on the valving, we took off the pressure reader, took off the valve handle and put a not in service tag on it. If you're getting involved with a new hospital build, that is the ideal time to nix the nitrous, as Stefan has kind of mentioned earlier, engaging as early as possible with the architects and engineering consultants, hospital and clinical leadership, specifically in anesthesiology and respirology, and facilities. is fantastic. Engage with everyone so that you can make sure that it gets addressed early. It's annoying for engineers to make drawings, then the hospital have to pay to go back and revise them. So the earlier you can get that done, the better. There's lots of evidence, show it to them. These webinars, there's lots of resources. You can see all the historical leakage at basically every site. That's what you're signing up for, is a very inefficient form of delivery. So even if you want nitrous oxide, you can improve the efficiency of giving it by going to portable or smaller tanks at point of use. And then, of course, the environmental impact is absolutely massive from these centralized systems and the amount of leakage they have. So again, addressing early, you save a lot of money in the construction costs from all the materials required to make a centralized system and distribute it everywhere. And then the ongoing maintenance, and then the purchasing of the nitrous itself. So there's savings all across the life cycle that you can use to help build a business case. So over the past year, since the last webinar that we gave, we have been busy. We've met with the CSA and made a compelling case to them to remove it from the MedGas table as needing terminal units and like diagnostic imaging and all these places where nitrous oxide is piped and never actually been used to begin with. So I think look forward to the 2027 release. Oh, there should be changes in there regarding this. That will be a big help, but if you're in a make or break situation right now, try and get ahead of that if time is of the essence for 2026 and the project you're working on. We've also been meeting with most of the provincial health authorities across Canada, which has been fantastic. Lots of them are reviewing how they can implement, kind of province-wide nixing of nitrous at their sites. And then we've had, the whole team, we've all had direct meetings and emails and conversations with so many people from many hospitals across Canada. And it's helping them overcome some challenges and provides support at kind of any stage that they're at. So it's kind of just a notice that if anyone on this call is interested, we are more than happy to have a meeting with you guys and help you along the way on this path. And with that, I'll hand it over to Catherine.
Whoops. I'm just gonna, if we can just go back one, please. Oh, here, I've got it. Got it. Thanks for giving me the chance to talk about my hospital's experience with nixing the nitrous in the OR. I'm a pediatric anesthesiologist at St. Justine, and I also run our acute pain service in the hospital. So of importance to note is that climate change disproportionately affects children, in particular when it comes to wildfire smoke and particulate matter. In children, we can see that there's an increased onset of asthma in kids that are exposed to wildfire smoke. Also recently, it was shown that children who have reactive airway disease, who have been exposed to wildfire smoke, are more likely to have adverse respiratory events under GA than children with reactive airway disease who have not been exposed to wildfire smoke. And adverse respiratory events under GA is a major daily consideration for the pediatric anesthesiologist. And lastly, also wildfire smoke exposure is consistently associated with increased rates of preterm birth and decreased birth weights in pregnant women who have been exposed to wildfire smoke and all the future health outcomes that comes with that. So basically, St. Justine is a big hospital, a quaternary hospital, and we have more than 3,000 births a year. It's the biggest combined obstetric pediatric center in Canada. We have the biggest neonatal ICU in Canada, level 1 pediatric trauma center, and we're the pediatric liver transplant center in Quebec. This is just a picture of the back of one of our machines in the OR. So basically, It's been a while that nitrous oxide has been decommissioned from our hospital, centralized nitrous oxide, I mean. It was sometime between 2010 and 2012 that we realized that we needed to do some major maintenance on our nitrous oxide piping. And the chief of the anesthesia department at the time had the foresight and wisdom to decide to decommission those pipelines and instead add nitrous oxide cylinders to the backs of our anesthesia machines. Over the years, in the operating room, we've used less and less of the nitrous oxide as people have become more and more aware of the global warming impact of using nitrous oxide. Um, when we looked at things in 2024 in our hospital, we saw that 41 of those E cylinders, like the 3 kilogram nitrous oxide cylinders, the ones that are equivalent to 1 ton of CO2, we noticed that 41 of those cylinders had to be changed in the OR. And one of the respiratory therapists and myself, we were both pretty surprised by that because we knew that it's not really so much in the zeitgeist of any of my colleagues to use that much nitrous oxide anymore for our inductions because of the environmental impact and because there's limited benefits for using it for general anesthesia purposes in peds. And so we actually the hypothesis was that we might actually just be using up all of those cylinders just due to the tests that we're doing on our machines every morning to check for leaks. And so we had some conversations with our colleagues, and people were not quite prepared to have the cylinders pulled off of the back of the machines because people can get pretty attached to practices that we're used to. But what we managed to get the okay from our colleagues was to shut off the valves on our nitrous oxide cylinders so that the morning tests on the machines were not done using the nitrous oxide. And so we weren't wasting any N2O during those tests. And that if anybody decided that they would want to use the nitrous oxide, there's occasional reasons that we need to use it for particular very uncooperative patients, but where we think they might have the rare case where you think you might have mask acceptance, just if there's no odor or to put in an IV beforehand, then if the anesthesiologist decided that it was indicated to use nitrous oxide, then they could open the valve and then there would have to be a 5-minute test that was done on the machine. So we implemented that change December 2024. And I haven't heard, there's 20 anesthesiologists in our department. I haven't heard any sort of complaints from anybody about the way that we're functioning now and we have respiratory therapists also, and everybody seems happy with it. And yeah, so that's what's been going on for the last year. The numbers that you're seeing here are cylinders that were purchased hospital-wide. In my hospital, it's not all of the years, but I just thought it was interesting to see how in 2010, when we were planning to switch to the e-cylinders instead of centralized nitrous oxide, there was a big jump between 2009 and 2010 of the nitrous oxide cylinders, but that was because so many cylinders were purchased in advance because people were worried that we wouldn't have enough. But as it turned out, the consumption of the cylinders went down over the years. And the 154 in 2024, this is for the whole hospital. So 41 of those cylinders were for the OR. And the majority of the other cylinders actually are in our dentistry because there's a dentistry practice in our hospital also. We also have Entonox, the Nitronox, the combined cylinders that's not included in this in this table that's used both by my ER colleagues and in obstetrics. And we were surprised to find out that obstetrics actually are consuming more of the Nitronox than the pediatric ER is using. I was talking to one of my colleagues about it today and who does a lot of obstetrics, and she was surprised by that, saying that it's pretty rare, as far as she knows, that patients are using nitrous as an analgesic in our hospital. But We're going to look into it more closely, but she was hypothesizing that maybe it's because the patients who need it, sometimes it's long labors, it's going on for a long time. So just one patient who's an adult also could be burning through a lot more of those cylinders than just short 10 to 15-minute pediatric procedures in the ER. So that's something that we're going to look at more closely. And of interest, I didn't have a chance to add this to the slide, but this is really good news, is that we just got our numbers back for the OR. And in 2025, similar to Dr. Williams' slide, we've had 0 nitrous oxide cylinders delivered to our OR in the last year. And that because the consumption just went down so much that we didn't need any new cylinders. One thing that comes up often when people talk about about doing mask inductions in pediatrics is how to have acceptance of the masks, and that's one of the arguments that people will use for using nitrous oxide for mask induction. Sometimes people will give the nitrous oxide for a minute or so until the child has relaxed more, and then switch over to the sevoflurane in the hopes that they won't notice the smell so much of the sevoflurane once we've switched over. It's actually becoming a controversial practice, even from a physiological point of view, because in any other clientele, you would never think of doing an induction with a patient who has not had a pre-oxygenation. And we're basically doing a deoxygenation when we do the nitrous before we start the sevoflurane induction, which could really be putting the patient into trouble if they have a laryngospasm subsequently and they haven't even had a proper pre-O2. So one of the main other reasons that people will still choose to use nitrous oxide just in the hopes of increasing mask acceptance. However, I've really found, and I used to be one of those people that I really thought that especially for patients that are very sensitive, autistic patients, that they might prefer to have a nitrous oxide induction. But I've really found with time that there's so many other ways to help, including pre-op preparation, child life specialists that make a plan with the child beforehand. Distraction is very helpful. Pre-meds, intranasal, IM, PO are all options. Putting the pre-op IV in with topical analgesia, then just doing an IV induction, so no need for SIVO, and also parental presence for select patients can help. And the last thing that I just wanted to show you here, I showed this in the presentation last year also, is this application that is so helpful. I really recommend it. It's free. It's called PD Pop, and it really increases mask acceptance. What happens is that I'll show the kid I'll show the kid the application in the pre-op area, and they'll see that they'll be able to choose what color balloon they'll want. And then once we're in the OR, I'll have them tap on the balloon of their choice, and then they're slowly blowing up the balloon, and so it's almost like a virtual reality thing where they think that they're actually controlling what's happening with the balloon. And it's unbelievable how many patients this works with. It doesn't always work. Nothing always works, but anytime that a new respiratory therapist who I'm working with sees this, they're just blown away because it's so effective. And I really do find it more effective than nitrous oxide for mask acceptance. So I really recommend that. And I believe that's taking us to my last slide. So here's my email if anybody has any questions that they only think about afterwards. So please don't hesitate to contact me. I'm pretty good at getting back to people. And on to the next speaker.
All right, that's your cue, Lisa. Oh, sorry, you're muted.
There we go. Sorry. So we came to realize that we really didn't know the nitrous use across Ontario, and so we created 2 QI projects to assess the nitrous use and delivery systems, as well as the attitude to change, to decommission, across Ontario. So we looked at two groups. We looked at a group of anesthesia chiefs. We sent out 119 surveys, and we had a 30% response rate, giving only 44 patients. And we also called a number of hospitals, which totaled out to 130, speaking with facilities and determining their desire to decommission, their desire and the present nitrous distribution system that they were using at the time. So I pressed something. Okay, so on the first slide, what we see is the preliminary data from the facilities call. We talked to 130 hospitals, and we ended up with this picture. What I was surprised to find was that a significant portion of the hospitals actually used no nitrous. And when that group was combined with the, which therefore had no leak, and when that group was combined with the hospitals that used e-tanks and the hospitals that were decommissioning or decommissioned, it represented the fact that about 50% of the hospitals were not having any nitrous leak. That left the other 50% basically to the centralized nitrous distribution group, which have significant leakage. They were about 44%, and let's see, they were about 44%. And when I extrapolated using the sample population to the Ontario hospital sites, I estimated that we probably have about 114 hospitals that will require being decommissioned if we're going to get 100% acceptance. So in addition, I guess of notes there, I guess that's the main part. We also, with the next slide, surveyed the anesthesia chiefs and looked at their desire to decommission their nitrous systems with a small group, only 44 people, and probably a bias in that those were the people that answered. We saw that 26% had no desire to change, but really the large 3/4 were at various levels and accepted the thought of change, with the category mostly of considering change, but the other groups were decommissioning, were in the groups of actively decommissioning, or planning decommissioning. So definitely a positive move towards thinking and planning for change. On the last slide, we looked at the perceived barriers of anesthesia chiefs on decommissioning, and the number one, people could pick any that applied to them, and facilities at about 42% were felt to be the biggest barrier to decommissioning. The finance came in close behind that, and so did anesthesia. Anesthesia often was expressed as being wanted for pediatric cases and for emergency C-sections were their main indication, and the worry that their tanks would run out. There are all good answers to these from an educational point of view. The other consideration that was down the road was time, and it's just important, I think, to realize that it doesn't have to be the anesthesia chief. It's very easy to delegate with successful decommissionings being done by RTs, anesthesia assistants, pharmacy, psychiatry, and residents, independent of or assisted by probably anesthesia chiefs, but not requiring much time because the leads are coming from other groups. I think those are my main points. Thank you.
Thanks, Lisa. Okay. So to finish us off today, I just wanted to share some info about our recently announced Nix the Nitrous recognition program. So this initiative is being released underneath the coalition's Nix the Nitrous and Preparing Canada's Healthcare Buildings for Net Zero project. And so basically, this program is recognizing healthcare facilities across Canada which have committed to decommissioning their centralized nitrous oxide systems. The goal of this has really just been to celebrate all of the amazing work that's been done so far, because we really can never celebrate these climate champions enough. We also want to show others what is possible. That's obviously the point of this webinar and some of the other work that we're doing, but really trying to inspire others to make this change and, let them know we don't need to reinvent the wheel. So whether a facility is fully decommissioned, partially decommissioned, or just even considering or planning decommissioning, we're inviting everyone to participate in this initiative. We're even thinking about how to incorporate those that, as Lisa mentioned, have never, had a centralized system, or for new builds aren't planning to implement that as well. So thinking about how to also recognize those facilities going forward. But for now, we have this. So to participate, facility representatives are invited to fill out our Google form, which is shown on this slide here. By the way, these slides are going to be sent out to all registrants as well, so don't need to worry about the QR code just yet. So I did want to share just what's come out of the initiative so far. So, like I said, we are recognizing those who are just planning to decommission and basically inviting them to join our Nix the Nitrous challenge, which is a pledge. And where, they are officially committing to decommissioning their centralized systems. So we've had 4 sign ups so far, which is exciting. Victoria General Hospital, BC Children and Women's Hospital, Saskatchewan Health Authority, and Port Perry Hospital. All of these participants have said that they are planning to decommission this year in 2026. And then here are all of our participants, which have either fully or partially decommissioned their centralized systems. These facilities are being recognized on our website and social media. So are the pledge participants as well. But we also have a case studies map, which I'll show on the next slide. And then fully decommissioned facilities are also receiving an official certificate of recognition from the coalition. And so this is our case studies map, which is going to live on our website. Here you will find all of the current participants, all of the future participants, and you can see kind of on the right side how it looks when you click on a particular facility. You can see some of the details and information about the activities undertaken and some of the results of the decommissioning. So again, that case study, here are the examples, here's how it's been done, and where it's been done. So I also wanted to just share some of the data we've collected so far. So each of these graphs includes responses from the 8 sites who have either fully or partially decommissioned. Also, the only one that's partial is London Health Sciences Centre, which does have, as Mike said, a few of his sites there are fully decommissioned. And so up first is approximate cost of decommissioning. You can see here that almost 67% of participants answered that it was a low cost, so under 5K, and 33% said it was a medium cost between 5 to 20K. And nobody said high or significant, which is great. We also have what the approximate cost savings were. So 67% said that they've had medium savings, so again, between 5 to 20K. 11% said high, between 20 to 50K, and 22% have claimed to have significant savings of over 50K. So I will mention that most of those who did have the significant savings decommissioned between 2022 and 2023, but all of the medium saving sides decommissioned in 2025, or almost all decommissioned in 2025. So even still, a year, maybe less, have seen medium amount of savings. So finally here we have the annual estimated carbon avoided from decommissioning, and almost 80% here said that it's been a game changer for them, and 22% have said it's a difference maker. I think that's to be expected after what we've heard from everyone today. So that's all from me. Thank you, everyone. We'll get into the Q&A now. Please feel free to put your questions in the chat, in the Q&A, and we will answer those.
Okay, I think Will Shipham had a great question that I think we do want to. Will, do you want? Are Autumn? Can they just ask their question? Can you give them permission to speak?
Can, yeah. If wanted to raise their hand, so anyone that would like to speak. So if Will, did you want to see if Will would ask his question
Yeah,
aloud?
Will, I think your question is a question we've gotten several times. So, and great, go ahead.
Hi, thank you. So yeah, I'm Will Shipham. I'm from BC Women's Hospital. And so we have a large obstetric unit with over 7,000 deliveries. And so my question is, we're in the planning of our decommission stage. And part of that comes to estimate how many tanks of nitrous or Entonox we're going to use. And so I wonder if any of the panelists had experience on how many cylinders they get through in an obstetric practice when they're converting over to portable units.
I could answer for our center. Oh, sorry, I don't know. Stefan, did you just unmute? You can go first if you want.
Go ahead, and I'll answer for us after.
Okay. So at St. Justine, we've got about 3,000 births a year, and I know how many Nitronox or Entonox cylinders were purchased in my hospital, so it's covering both obstetrics and the ER. But obstetrics was a bigger user. I don't know the division between them. But in 2024, 195 Entonox cylinders were used. And in 2023, 177 cylinders were used in combined between obstetrics and the peds ER for procedural sedation for 3,000 births a year in a high risk center.
I have data for our hospital, which is between 2,000 and 2,500 births a year, and we're at about 80 Entonox cylinders. But I have seen other hospitals that use a lot more, and I have seen a lot of other hospitals that use zero nitrous oxide for delivery analgesia, for all the reasons that we talked about earlier. So it does really seem to be not a medical need, but more of a cultural, a local culture, a local medical culture issue where people have different ways of treating the pain associated with childbirth. And some turn to nitrous very quickly and a lot, and some don't use nitrous at all. I don't know if that's helpful for calculating the amount of cylinders you're going to use.
Yeah, thank you. I think that's really helpful, in part because that's some of the kind of questions that come up from the management side as well. So we have to address the issues. Plus in BC, we seem to have some kind of discussion about cylinder shortages. So again, it's kind of planning for us. You're right, it's definitely a cultural thing. And so we've kind of audited how much nitrous we use in labour to give us a rough idea. And it's probably similar to Kathy, some of your actual usage estimates for what we use. But until we actually make the transition, we obviously won't know for sure. But it's really interesting. I know places in Australia actually tried to stop using nitrous for labour analgesia altogether, and that made the newspaper headlines, and they soon rescinded that. So it's a very delicate balance of kind of using it appropriately and then trying to advise your patients when and when not to use it.
I think the idea that the Quebec midwives have to talk about it a long time in advance is probably a very good one.
Go ahead, Kathy.
Yeah, sorry, I don't know why, but for some reason my settings, I can't find the hand raise, so I'm just going analog. Um, but I totally agree that it's a cultural thing, and I think it's really important for hospitals to be educating patients about their obstetric analgesia options way ahead of the big day, and which most hospitals do. But I find it just so cool that the Quebec midwives put out that pamphlet. I forgot to pass it on to our birthing center. I just passed it on to them just today because I think it's really interesting to give women the choice of what they want to be doing for their analgesia. And I think that often it's really not a totally informed consent when people are accepting nitrous oxide, that if they really realized the impact that it was having, and if they had the chance to think about it before they're in pain, I'm not talking about the day of, but if they had the chance to think about it beforehand, they really might want to explore other options that could be just as good, just as safe, and possibly more effective. I mean, obviously, we all know that the epidural is like the best, but that's not always an option. But there's other options also, like remifentanil, PCAs, or stuff like that.
We've got a question from Katie. Katie, do you want to ask your question or do you want me to read it? If you want to ask your question, just go ahead. I'll read your question and we can have a discussion after we read it out. And Katie writes, we are in the very early stages of this project at Mount Sinai, which is in Toronto. And besides anesthesia, building services, and biomedical engineering, is there any other department that needs to be involved to support this initiative? So, Katie, I think Mount Sinai is very similar to Trillium. We have 8,700 deliveries a year. We've just put both of our sites together in our site. So I'm now going to be monitoring the tanks because our two sites have just combined. We barely use nitrous oxide for labor analgesia. We have two dedicated obstetrical anesthesiologists. So there is epidural on demand. Probably the longest they're waiting is 15 minutes, if that. And so we bought 4 portable systems, and I barely see it being used. Our nurses were used to the portable system before they only hooked up the central system during COVID, unfortunately. So then we decommissioned that. So very, very little, but you would have to definitely engage with your obstetrical department and their chief and the obstetrical labor and delivery nurses. Katie, just let us know if you have any follow-up questions from that answer. Anyone else want to answer, Katie?
I'll just add a little bit of information. When our hospital was built, nitrous was piped only to the OR. So no other clinical stakeholder was using the central system other than anesthesia. If that's the case at your hospital, it makes things very simple. If it has been piped everywhere and people are using it for other uses, then I guess you have to talk to all those other people.
Yeah, I'll just add from my own experience, if you can get a hold of the MedGas table at the end, it does designate a lot of places. And so for us, it's like diagnostics imaging, the emergency department, other random areas that used to be something where you would take nitrous oxide, but then they changed it into something else, and people just didn't know why they had nitrous oxide terminal units there. One of our systems that we decommissioned was dentistry for sure. Another one was labs. We had some research labs in our buildings that had nitrous oxide going to them for some random reason as well. Again, so it's literally going door to door, at least what I had to do, and say, hey, do you guys use this? Has it ever been used? Do you ever plan to use it in the future? And like every single case, the answer is no. But it's documenting that, and it is just every system's slightly different. It'd be wonderful. Like I wish it was just the ORs for us. It'd make my life so much easier. But yeah, no, you do need to make sure you're engaging all the stakeholders and just making sure that no one's using it for some other weird random use.
We actually used the blueprints, and that really helped us find a number of ones that we didn't anticipate at all.
Yeah.
DI was one area that we had it piped in, and it was important in the new build because we actually had to engage with diagnostic imaging and get the sign off of the chiefs that we didn't have to put it in our new hospital redevelopment. And they didn't know that they had it even, so they had never used it.
This should all change soon, I hope, with new CSA guidelines, assuming they incorporate the suggestions we've provided. So,
Well, I think if there's no other questions, we're just at about time, and where you can always reach us. Our email is available. Oh, I'm sorry. Well, go ahead.
So I thought I might just use this as another quick question opportunity. I know another stumbling point ourselves have had, and other health authorities in BC, is that to actually make the transition, the hospitals that still want to have some form of nitrous oxide or the anaesthetic machines, as for the reasons discussed, this either means kind of a costly retrofit if you have large fleets, or waiting for the anaesthetic machines to be upgraded, for example, which can be 1, 2, 3, 5 years. Obviously, delays things massively. So, I wonder if you had any advice on either of those options.
I can tell you that it was between 1,500 and 2,500 to retrofit our machine. We did not have a yoke available for nitrous oxide, and that is when we had 50 machines. That's when we just said no. You're not getting nitrous. If you really want nitrous for an IV start, we have to walk over to obstetrics, which is not far, but it's a 5-minute walk. Bring the system over. It's been done twice in 3 years. So we've had a couple of locums who were surprised that we didn't have nitrous available for use, but humans adapt very quickly. We are a regional pediatrics and obstetrics center, and I have had not even complaints, but 3 inquiries about, oh, we didn't have nitrous. It would have been nice for this case. And that's it. And twice people walked over to the obstetrics. They had to hook it up to the scavenging, open it up. And I think after that experience, they thought it's just not worth it. So we have a very supportive chief, though. That is one thing I can say, who took that stand. Stefan?
Just like to emphasize that the practice that Anita is describing is in accordance with Canadian Anesthesiologist Society guidelines. That's the way our guidelines tell us to practice now. It's not a compromise, it's the right way to practice in 2026.
Great, thank you.
Yeah, well, and it's just going to say, like, I know what we'll be doing is just portable tanks on a dolly that can be brought in if needed, and then they'll rerun their anesthesia cart testing once it's connected.
Will, can I ask, is it those who are doing the pediatrics that really want it on the machine?
It's a mixture. To be fair, our pediatric department are part of the Spruce project, and so they've massively cut down their nitrous oxide use. But they still want to have the ability. And similarly for our obstetrics, we only really do obstetrics and pediatrics on our site. But I know the Victoria General Hospital had similar problems with their anaesthetic team, not willing to give up complete use, and then biomeds get involved and say, well, every anaesthetic machine must be the same. But I do like obviously the idea of actually just having nitrous oxide on wheels that you can plumb in, because that's the infrastructure is already there
Yeah.
as an alternative.
The other option is if you do use a lot of it, again, this is like hedging against everything that, Anita wants to not use it anymore. But you can like get a tank and wall mount it in an OR, right? Is that cheaper than the $1,500 to retrofit a cart? I don't know. But it's certainly an option as well. There's little wall mount brackets, and you could have the same thing mounted, hard mounted in every room, and even use a larger tank, but then they get a little bit more unwieldy to actually, swap out when you need to. But
And
yeah.
those tanks do get left open. I think
Yeah.
that's part of my problem too, is I went to just check the stands and the integrity of the stands when we first built the stands in obstetrics, and the tank was completely empty because it was left open. So there's another source of carbon or GHG emissions. We don't even use it in obstetrics, but if you leave a tank open, someone's going to replace that tank. So the less tanks around, the less they'll be inadvertently opened. But I understand that it's a transition for some people. And I should clarify, the two people who brought the tank over, it was not to run an anesthetic. It was to put in an IV in an anxious teenager. So we have zero ability in our OR to run a GA with nitrous. It's only for IV insertion. Kathy.
Yeah, I just wanted to add one other thing, which is that when I had surveyed my colleagues when we were trying to figure out if we could just completely get rid of the external tanks in the OR, I think it was about 25% of my colleagues that felt like I'd still like to have nitrous sometimes for specific situations. And at that point, I felt sort of like I don't know what to do with this because it's hard to tell people that they can't have something that they think that they require for safety, even if I don't believe that's the case. But then what we did is that well, actually, Stefan spoke to another one of my colleagues who's kind of like more politically charismatic than I am, and he has a strong environmental stance also. And he just wrote an email to the department saying, this is what we're doing. If you have any, we're just going to shut the valves on these machines. And if you have any questions, you can talk to me about it. And that was it. And then it was like silence after that. Like sometimes it's also just finding the right person to just put their foot down. Kind of like what Anita was saying about having a supportive chief who just said that you're going to have to go get the nitronox from obstetrics. But it's kind of choosing the right person who's going to get away with that kind of action too. It's a bit of politics.
If there's no other questions at this time, you can always reach us. Our emails are on the slides, some of them. And if not, if you want to speak to someone directly, Autumn can connect you with us, and we're here to help. So that's it. Thank you very much for attending.
Thanks, everyone. Have a great evening. Take care.